Friends, I hope you're hearing me. I'm having some internet instability, but delighted to welcome this week an old friend, Dr. James Rusthoven, who is Professor Emeritus, the Department of Oncology at McMaster University, and Research Fellow in the Kirby Lang Center for Public Theology in Cambridge. Dr. Rusthoven was born and raised in Chicagoland. He graduated from the University of Illinois School of Medicine, and then migrated north with his wife to Canada, where he completed residency in Toronto. Then at the University of Chicago, completed a fellowship in infectious diseases, and then after that, a fellowship in medical oncology in Toronto. And then for a couple of decades, Dr. Rusthoven practiced medicine while teaching and conducting research at the University of Toronto and McMaster Universities. He worked in pharma for 3 years, helping to develop a novel cancer drug. He then resumed clinical practice while completing graduate work in biomedical ethics, first at the University of Toronto, and then completing his PhD in theology at Trinity College, University of Bristol. Since that time, Dr. Rusthoven's work has mixed clinical care for patients with cancer with teaching biomedical ethics in different contexts, and recently working for a few years for Health Canada, which is, as he'll describe more about that, but for Health Canada to evaluate new cancer biologics. Dr. Rusthoven is the author of Covenantal Biomedical Ethics for Contemporary Medicine, which was published by Wipf & Stock in 2014. If you're interested in how the Reformed tradition speaks to medicine and medical ethics, particularly, I commend that book to you. Today, Dr. Rusthoven is going to speak with the title of Living Out an Intentional Theology of Faithful Presence in Medicine. And we'll trace some of his unique history and how he thinks about a Reformed philosophy and theology shaping the way he cares for patients, the way he thinks about medical ethics, and the way he thinks about regulation of medical technologies. Dr. Rusthoven, welcome.
Thank you very much, Far, and thank you for the opportunity to speak at this final opportunity of this series. Let me just put my slide share on here a moment. Okay. Right, so Far and I first met at the first conference on medicine and religion back in Chicago. And at that time, I was working out a Kuyperian vision of Christian living and witness within relationships in my oncology practice. This vision included living out biblical premises of God's sovereignty over each distinct sphere of life and relating to my patients in trust with honesty and integrity. I would also like to acknowledge the timing of this seminar. It's occurring a full year, almost to the day, after one of my most admired and respected bioethics colleagues, Gil Meilander, spoke at last year's TMC series. Dr. Meilander noted that much work in bioethics today involves slotting bioethical problems into a grid of a few basic principles and hoping one gets some answers. While such a ready-made, simple ethical system, as he puts it, may have a better chance of reaching a consensus on answering bioethical questions, such a consensus is often a pretty thin lowest common denominator consensus. His underlying premise was that it doesn't really work to apply principles in a vacuum. In fact, he said what we do with those principles will depend on our basic background beliefs that each of us carries with us in life. His thesis was better understanding our foundational beliefs can enrich our thinking about these problems in more meaningful ways. So here we are a year later. What I would like to do is continue along Dr. Meilander's line of thinking. That is, how can we understand how the core scriptured filtered beliefs of our Christian traditions teach us about working faithfully as a presence in the world of medicine? I'd like to share my thinking as a medical practitioner in two interrelated themes. One theme is how can we practice faithful presence as a theology of commitment and promise, a covenantal commitment imitating the new covenant between Christ and his followers in relating to our patients, our colleagues, and other stakeholders in medicine. The second theme is conceptualizing a practice within a Christian foundational structure of practice. Now, my journey began already in undergraduate years, where I was opened up to the richness of a reformational worldview, first developed by Abraham Kuyper and later by Herman Doiver. In this worldview, created reality can be understood as irreducible dimensions of God's created order, some of which are norms involving human deliberation and action, like that list you see on the right of this slide. And a key component is developing the knowledge and skill to discern the worldviews of our age. A concrete contemporary interpretation, I think, of 1 John 4, where the Apostle John entreats believers to beware of false prophets and spirits that may influence them. Test the spirits to see whether they are from God, says John. Every spirit that does not acknowledge Jesus is not from God. You, dear children, are from God and have overcome them, because the one who is in you is greater than the one who is in the world. They are from the world, and therefore speak from the viewpoint of the world, and the world listens to them. Now, once the Lord put me on the path of medical training, I needed to continue improving those skills of spirit and worldview discernment while absorbing the explosion of medical knowledge fed to me and applying it to the structure of medical practice norms. As my colleague Hank Jochumsen has noted, medical practice shapes the behavior of individual practitioners before they can begin to reshape the practice. Providentially, I believe, during my first year of internship, way back in 1976, the first issue of the Journal of Medicine and Philosophy appeared. Through its pages, in my spare time, I was introduced to subjects ranging from contemporary bioethics of the day to explorations into Greek and Semitic concepts of health and disease. I became familiar with the writings of co-founding editors Edmund Pellegrino and Tristan Engelhardt, as well as Richard Zahner, Stephen Toulmin, and Alistair McIntyre, to name just a few. I increasingly experienced the cultural tension between the Reformed desire to rest in the sovereign will of God and the modernist desire to rest in the power of the medical technology and medicalization of human frailty prominent in the day. I also started reading the writings of Alan Verhey, which did much to tune my Reformed sensitivities in ethics and medicine, and who wrote so perceptively in his later work, Remembering Jesus, about sickness and suffering as a mark of the not yet character of Christian existence. But sickness also encompasses a watchfulness that forms courage and patience. While such watchfulness evokes lament and even grief at times, the contemporary path to heroic discipleship can also witness to courage and hope of the coming consummation by dismissing suggestions of assisted suicide and offers of dubious treatments that offer more risks than benefits to quality of life. Exposure to formative evangelicals further enriched my Christian perspective for medicine and life in those days. During medical school, I started worshiping at the LaSalle Street Church, and later the Evangelical Free Circle Church in downtown Chicago, learning how Jim Wallace and the then new Sojourners movement envisioned a new evangelical consciousness developing biblically inspired new forms of socio-political engagement. I also participated in sharing strategies for vocational witnessing with fellow congregants, joining a midweek medical gathering, physicians, nurses, and healthcare trainees like myself. There was even a gathering of workers committed to witnessing on the floor of the Chicago Stock Exchange. What a wonderful expression of a Reformed worldview, I thought. Why couldn't more Reformed churches introduce a participatory theology into their worship and non-worship life? And finally, the inspiring seminar presented just a few weeks ago by Daisy Dowell brought back the vision of my classmate, John Barron, and our nursing friend, Nita Dade. After graduation, John and Nita established the Circle Christian Health Center in the poor Chicago district of Austin. where racial tensions grew steadily at the border of all-white Oak Park. While I felt God's calling in a different direction, I remain thankful for their sacrificial kingdom work and inspiration. Now, after medical school, my wife and I moved to Canada, as Farr mentioned, which I did all but 1 year of my general medical and specialty training. As a Christian medical oncologist in a regional cancer center in Toronto, and then later Hamilton and McMaster University, I grew to increasingly appreciate my Reformed tradition, reflecting often and very intentionally on how I should understand the norms of medical practice through scripturally tinted glasses. Over the last 25 years, I've tried to work out my developing Christian perspective in two distinct but interrelated areas of medicine, the most dominant and first being clinical practice of oncology, the later being regulatory medicine, within which I engaged for 4 years in judging whether clinical trials of new cancer biologics showed sufficient efficacy and safety to be authorized for marketing to appropriately needy patients. I will touch on each of these areas over the remainder of this seminar. So during the first 15 years of oncology practice, I increasingly realized the importance of establishing a meaningful relationship with new cancer patients at that important first visit. That skill development was difficult at first, in large part because it was counter to the probing litany of intense questioning that I was trained to engage in to hone in on a diagnosis and lay out a treatment plan. Indeed, learning the practice had shaped me before I could reshape the practice. However, I learned quickly that faithful presence also included faithful silence. Listening to the patient's initial cancer journey through their words and perceptions, understanding their struggles while listening carefully for windows of empathic opportunity that would help me to ease onto their path and walk beside them. One of my intentional points of engagement was probing sources from which each patient drew strength in dealing with adversity. Did they believe in God, Allah, or other source of existential comfort and power to whom I could help them relate? I would insist on the patient bringing a trusted other person with them to their clinic sessions, allowing that person to be their extra memory and interpreter of what I said, of what we agreed on regarding treatment, and of expectations at different junctures along their cancer path. I told them that once they left the clinic and opened the door of their car, they would have remembered about 25% of what we had talked about without such a person. Most of my patients came first to me with extensive metastatic disease at diagnosis or recurrence after initial attempts at curative surgery, plus or minus radiation. Often there was little or no expectation of cure. We would discuss what that meant for treatment choices and their quality of life during and after treatment. Another manifestation of faithful presence was being forthright, yet sensitive, when discussing realistic expectations of improvements in quality and duration of life resulting from recommended therapies. Sometimes the Lord will seem to tell you outright if that faithful presence is being felt by colleagues and patients. For example, after 23 years of training and practice with no sabbatical, I began a 3-year vocational sidebar as a clinical researcher for a pharmaceutical company. In large part, to understand the pharma mindset from within. I wanted to continue teaching at the medical school, but I proposed to my dean of medicine that my academic status be changed from professor of medicine to some adjunct status. In the course of our discussion, the dean acknowledged that he did not really know me personally very well, but having talked to colleagues in the department before our meeting, he said the 2 words stood out in characterizing me as a physician and colleague: honesty and integrity. I took that as a sign that I was probably on the right track as a faithful presence in my practice, at least in the eyes of my colleagues. During that vocational sidebar, I helped to lead a development of a promising new cancer drug. One incident particularly stands out as a manifestation of my attempts at faithful presence, as well as a stimulus to do graduate work later in bioethics. I had crafted a compassionate use program with the new drug I was helping to develop. Eligible patients had to be well-functioning, and the tumor had to be progressing despite having tried all approved therapies. One day I received a call from my boss who said that the mother of a close friend, lawyer friend of our CEO with extensive cancer had tried all approved treatments and now wanted to try our drug on this new compassionate use program. I reviewed her chart, and in my judgment, the lawyer's mother was too ill to qualify for treatment. But pressure was brought to bear on me to make an exception in this particular case. Well, after several rather intense discussions with my boss, I said I would consider that request, but only if the protocol was changed to allow other patients with that degree of debility to receive the drug and its significantly increased risks. I reminded my boss that FDA carefully scrutinizes patient deaths for evidence of causation due to experimental drugs. Now, admittedly, that was a bit of a Solomonic strategy. I did not want to make an exception as a favor to our CEO's influential friend, yet I knew that the company would not likely risk scarring the image of the drug by risking increased morbidity and death related to the drug. In the end, my boss agreed with my decision not to make this exception, and the company CEO, to his credit, accepted my decision and informed his not too pleased lawyer friend. However, I also knew a Canadian colleague in new drug development at the Mayo Clinic who had a clinical trial of another drug for which that patient was qualified, and the patient was admitted to that trial. And the Mayo Clinic was much closer to where she lived than where I was. After my 3 years working with industry, I returned to part-time practice and felt called to graduate studies in theology and biomedical ethics. For the next 7 years, I had a part-time community practice. I taught a bioethics course for undergraduates at a Christian college. I studied current dominant paradigms in bioethics toward a master's degree, and then probed Christian perspectives toward a PhD in theology on a thesis of biblical covenant informing medical practice relationships. During the time of study, I came to see that a theology of faithful presence has as its foundation acknowledgement of God's faithful presence to us and our reciprocated faithful presence to him, both individually and as church. Within the body of Christ, we work to overcome divisiveness along lines of social class, ethnicity, race, and other barriers through the special grace of Scripture. Outside of that community, we are to follow that same gracious word in our encounters with strangers, whereby God's common grace to our fallen world breaks through base human tendencies to be suspicious of strangers, if not outright hostile. To welcome the stranger is to welcome Christ. Again, faithful presence requires a theology of covenantal commitment and promise, imitating the new covenant between Christ and his followers. Appeals to covenantal relating in medical literature was increasingly surfacing in the late 1990s and early 2000s during my PhD studies, coming from nurses, physicians, and medical educators. Now, while such appeals are often based on the Judeo-Christian tradition, some were also based on the Hippocratic Oath. But the common motive was a reaction to a contractual idea of relationships that had arisen due to a lack of trust and increased risks of abuse in medical practice. I also increasingly appreciated the normative reflective practice model developed by Reformed colleagues in the Netherlands, which understands medical practice as having constitutive rules or norms that are carried out or expressed under the influence of a regulative direction flowing from the worldview and faith commitment of practitioner. As my theology of covenant became more intentionally entwined in my practice, I sought to gain patient trust while also emphasizing the importance of patient compliance. toward the ultimate goal of meeting their needs. I began to explore how covenantal relating might enrich other relationships with stakeholders in practice, in clinical research, and later in my role as an evaluator of new cancer biologics. Now, being a faithful presence also involves imagination and improvisation, a skill known all too well to practitioners who form professional relationships with a wide range of patients with very different characters and historical baggage. Practitioners must get permission to drop into their narrative of their patients as fellow human beings, first looking from the outside in with a life-altering task. Over time, oncologists in particular become an integral part of their new narrative of realizing and dealing with cancer. In palliative care, that relationship becomes more intimate and intense. To be a faithful presence to a patient is to know when to listen carefully and identify windows of opportunity to earn a trustworthy place beside them in their end-of-life walk with cancer. As Richard Zahner relates in his essay, Encountering the Other, sense of place is particularly important. For all patients, in a temporally limited sense, but especially for terminally ill patients, their room is their space. We move physically into their end-of-life narrative and its space. We should feel the need to be invited into their domain, and such patients dominate the scene because of their intense vulnerability. So while Christian practitioners must learn and understand the norms for a practice for which they train, they must also develop what Charles Taylor and subsequently Jamie Smith have called social imaginaries. For medical practitioners, it's engaging in the practice of medicine in affective, non-cognitive ways embedded within core beliefs of one's worldview and through which practice as shared relationships is carried out. In the medical context specifically, spirituality is imagined as a religious and/or existential mode of functioning through which a practitioner answers the questions of meaning and purpose played out in clinical experiences. Smith uses the notion of spirituality functioning through liturgies that shape and constitute our most fundamental desires and most basic attunement to that world around us. Embedded in every liturgical type is a worldview from which the liturgy teaches us to be a certain kind of person. Now, spirituality can be experienced in several ways, informing professional identity development, including transcendence and inspiration, seeking guidance and discernment through prayer and the study of Scripture, and understanding the history and traditions of one's type of practice. Now, I struggled with the meaning of spirituality in the early days of my training. In fact, I remember friends who related personal concerns about their family doctor, a visibly dedicated Christian family physician. He committed regular office time praying with his patients. But my friends confessed that they would have gained more from those engagements if their doctor had projected more confidence in his professional depth of knowledge of care as a family doctor. I recall a practical expression of social imaginary for liturgy in the care of a middle-aged woman with advanced cancer. She'd been diagnosed with stage 4 ovarian cancer, and in her first visit, we discussed her diagnosis and prognosis. I told her that in my professional judgment, her disease was very likely incurable. But any recommended treatment that would be offered would be with the express goal of keeping her as well as possible for as long as possible. During the course of our first visit and my routine inquiry about what gave her meaning and strength, she told me she was a devout Roman Catholic, routinely participated in Mass, and observed religious holidays such as Christmas and Easter, but also those dedicated to particular saints. In turn, I informed her that I was a Christian in a Protestant tradition and would help her in her faith journey as much as I could from my understanding of Scripture and how it would speak to the various points along her journey with cancer. She explained to me that she understood about what I had proposed as an initial treatment plan, and she asked if we could link our meetings to assess the various outcomes after therapy with various holy days of the Roman Catholic calendar. We tried to pick follow-up appointments on or near a holy day, commemorating a saint or an important religious event. She thought it would give her some comfort and strength in linking their earthly struggles with her challenges in living with cancer. As an important part of her religious life, these remembrances of saintly predecessors was was part of her religious or liturgical experience through which she felt communion with God. Her walk with cancer gained meaning for her life walk. I was just thankful to be led into her journey as one of her trusted others. So I scheduled her treatments and follow-up visits as closely as I could to her choice of religious holidays. She experienced a relatively low level of pain and discomfort during treatments. And for each visit, I tried to learn as much as I could about a particular saint or other holy day event tied to that visit. Exceptionally, her clinical course extended nearly 4 years before she died peacefully at our local hospice. Through my reflections on my practice, I came to agree with Edmund Pellegrino that an ethic of care, or beneficence and trust, as he called it, is at the core of medical practice. I contend that the most meaningful expression of an ethic of covenant in medicine is a biblical expression of the ethical aspect of Christian medical practice. As theologian Gordon Spikeman has eloquently put it, the covenant theme is a golden thread weaving its way through the total fabric of biblical revelation and redemptive history. It defines the fundamental structures undergirding all human relationships in every societal calling, including medicine. But such an ethic drives also the ethos or overarching spirit of a practice, encompassing a basic attitude toward life as well as its integrating direction, forming our character and dispositions through expressions of our virtues. All aspects of human functioning, such as social, ethical, psychic, and economic, are operative within the complex of medical relationships that make up a practice. The interactions of these aspects of functioning as specific relationships will vary, and their normativity as God's creational law may be distorted. Indeed, such a growing appreciation for the central role of ethics of care and realizing its importance in developing new cancer treatments while working with industry had drawn me to graduate studies in bioethics. As noted by Dr. Mylander's seminar last year, I also found in my graduate work that principles-based ethics, as derived from common morality theory, could not satisfy a robust Christian perspective, lacking grounding in ethical norms outside of human reason and judgment alone. The lack of emphasis on relational aspects of medicine particularly troubled me. With appeals to the literature, to a concept of covenant by Christian and non-Christian healthcare providers and teachers alike, I focused on how the theme of covenant could be expressed in medicine as being faithfully present in medical relationships. Now, earlier, I mentioned another area of medicine in which I worked to develop a faithful and formative presence. With experience as a clinical investigator, designing, implementing, and interpreting clinical trials with the Canadian National Clinical Trials Group, I more recently took a role as medical officer and reviewer of new cancer biologics for the Canadian National Regulatory Agency. In efforts to serve the public good, medical regulators of new therapies must review extensive basic and clinical research portfolios submitted by drug companies. They must be on alert to recognize clinical trial designs results and interpretations that can distort the true nature of therapeutic efficacy and or safety, and inappropriately slant results in favor of new therapies. Unlike the internal good pursued by caregivers and most other stakeholders in medicine, the ultimate good for pharmaceutical companies is improved profits for shareholders. As the only medical oncologist in my division at Health Canada, I spent a good portion of my time providing what I called curbside consults for my non-clinical regulatory colleagues. I repeatedly reminded them of the economic priorities of the sponsors, pointing out trial designs, trial interpretations, statistical shortcuts that would be part of a sponsor's strategy to get their therapy quickly and more cheaply to market, even if at the expense of patient well-being. For me, caring included attentiveness to ethical norms for demonstrating the benefits over the risks of new therapies to fellow image bearers of God in need. With my pharma background, I had no difficulty challenging company authorities when ethical concerns needed to be raised. This could include failing to change the control therapy during a randomized trial when the standard of practice had changed midway through the pivotal trial, or using a trial design that avoided obtaining a result for a meaningful clinical outcome, leading to a result that had an unacceptable degree of uncertainty as to its true efficacy and safety. For me, a faithful presence was going beyond sharing my faith with fellow Christian regulators to include identifying and following norms of maximizing clinically meaningful measures of efficacy and safety. Now, thankfully, some pharmaceutical companies have made efforts to make patient care a higher priority of purpose, using their profits to improve healthcare in poor countries. Prominent examples have included Avant Immunotherapeutics through the efforts of its CEO, Una Ryan, in the early 2000s, and later Andrew Whitty in the years following his 2008 appointment as CEO of GlaxoSmithKline. Now, by 2010, GSK ranked #1 on the index of the third-party Access to Medicines Foundation that ranks pharma companies according to several parameters, particularly their demonstrated contribution to supporting healthcare for the poor. On the recipient side of healthcare, organizations like the Interfaith Center for Corporation Responsibility help to support Christian and other sensitive shareholders who try to influence company board decision-making to feed their profits back into healthcare for particularly needy healthcare systems in poor countries. I just want to remind us all that as Christians, we must always seek out windows of opportunity to draw attention to or outright correct aberrations or inadequacies of medicine when the Lord puts them before us. One such opportunity came to me during my graduate studies. After I left the pharmaceutical company, my previous boss had moved to GlaxoSmithKline. We continued corresponding, and he invited me to share my PhD work in bioethics. Under its recently hired CEO, Andrew Whitty, GSK had decided to price its drugs in poorer countries no more than 25% of the cost in rich countries, and donating 20% of all profits in poor countries back into building up their healthcare systems. I shared my work in covenantal ethics in medicine in my talk, showing how much an ethical framework might be applied to relationships between industry and various shareholders in medicine. While lauding the GSK leaders present for using their profits for poor countries to improve healthcare in those countries, I suggested a next step toward an even greater commitment to improving global patient care from their profits. I suggested that they consider, in addition to the current policy, further contributing 5 to 10% of profits from wealthier countries to further narrow the widening global healthcare gap and demonstrate even more convincingly their commitment to healthcare for the poor and most needy. Making a faithful presence among those with power to help the poor and needy should never be passed up for the sake of our Lord's kingdom on this earth. I'd like to conclude by acknowledging the unselfish and most patient mentorship of Craig Bartholomew, my PhD supervisor and current director of the Kirby Lang Center for Public Theology in Cambridge, in England. Craig broadened my vision of reformed thinking into the field of medicine in overseeing my PhD dissertation on covenantal relating. I would also wish to thank Richard Mao for his positive influence on my faith journey, particularly in the areas of common grace and public theology. Now, Mao has labeled himself as an evangelical Calvinist in past writings, though in a recent Trinity Forum discussion on being a patriotic Christian, he noted that he was, at least on that day, a Calvinistic evangelical. Now, the evangelical part was ingrained in his childhood and early adult upbringing, and the Calvinist part took deep root and matured later, strongly influenced by the life and work of one Abraham Kuyper. Now, personally, I'm not a fan of attaching labels to fellow humans unless done to give mutually understood clarity in sharing basic beliefs. Indeed, exemplifying the risks of such labeling I would not consider myself a Maoist, evangelical or otherwise, and risk a very wrong association with a well-known antithetical worldview. Thank you very much.
Thank you, Jim. And let me say to folks here that if you'd like to ask a question, you can either put it in the chat to me, or you can use the reactions button below to raise your hand in Zoom, and I'll call on you. And when I do, I'll ask you to turn your microphone on and your video on to ask your question. But to get us started, let me ask you, Jim, we have, Stanley Hauerwas, as you know, has been very influential to us here at Duke and a mentor to many of us. And he famously said that if medicine is at its heart a matter of presence to those who are hurting, who are suffering, then medicine needs something like the church to form that capacity. And I'm curious how, if at all, you've become conscious of how the formation of your practices as a Christian in the church, I mean, you've mentioned the sojourners and you've mentioned groups meeting and Bible study and so on, but where you maybe been aware of that forming you to, for example, let's just say either forming you to be capable of being with those folks you've taken care of who have advanced cancer, or to show up as you did and show a bit of backbone regarding the compassionate care situation, and or speaking a little propheticness to the pharma executives, suggesting they give more of profits to reduce disparities. Were you conscious of how those things were coming together?
Yeah, I mean, as I said in my presentation, that my consciousness of myself and how I practice as a Christian evolved partly on a basis of experience, partly on the basis of a deepening of my faith rather than a losing of my faith. I took very seriously the fact that I will be much more influenced before I can influence with respect to my practice. And that's a struggle. Unless you're in a context where you have a close group of fellow Christians in your practice, that can be difficult. Now, in Canada, we have regional cancer centers, and that's for a reason, because not only it allows radiation therapy facilities to be more effectively used, but we actually had clinics during the part of my oncology fellowship where we had all oncologists together, a surgical oncologist, a radiation oncologist, a medical oncologist, all in the same room at the same time, or in the same clinic. So patients didn't have to keep coming back and forth when you had treatment that would involve more than one modality. And that was fabulous. I mean, I think that was an innovation of practice which clearly addressed the issue of helping patients in other dimensions where we often don't think about it. We might say it's convenience, but it's not just convenience. It's having them see that we as an organization are sensitive to those kinds of very practical needs. And I think that's a clear ethical plus. Now, at one point, the administration decided it was too expensive, so they broke it up. And then about 5 years later, they reinstituted it because of the protests that came through patients as well as physicians. So again, it does depend on your setting. You know, Tristan Engelhardt wrote his book on bioethics and Christian foundations, the second version, when he was Eastern Orthodox. And I'll give him credit. He tried to articulate a kind of medicine that incorporated Orthodox teaching and practice at a public health level. And I'd never seen anybody quite so boldly give that a try. I didn't do it. I couldn't do it. I wish other people would be maybe bolder than I could be. But I think that's the kind of thing which reflects a growing sensitivity in one's idea of what practice means, both for the bedside and our character as expressed at the bedside, but also the power that we can wield for patients at a higher level. I think COVID was one of the big eye-openers for many people on this because of the stress, particularly in Canada as well, of course, the stresses on already a beleaguered system in terms of the number of people taking care of critically ill patients. I don't know whether that's going to have a lasting positive effect on bolstering the healthcare in Canada, but I certainly know among colleagues, it's been a good witnessing experience, tragic as it was. So I don't have any ready-made answers in that sense, but as I tried to allude to in my presentation, I try to at least personally be able to witness to patients in ways that would early on identify where their strengths were in going through what inevitably would be a very difficult path for them. And we at the cancer clinic would be a part of their life that they just weeks before they had never dreamed.
Jim, let me pick up on that. Let me pick up on that to maybe push in there a little further. You mentioned our late friend Tris Engelhardt, who was, if nothing else, bold and unashamed and forthright in his claim that, you know, if you're going to have a bioethics among moral friends, you need a religion, and be careful to choose the right one, as he put it. But you talked about this way that you figured that you would interact with patients to ask them about what's important to them, to ask them about the key people in their life. You obviously were open to dialogue about spiritual and Christian concerns. And you use the term of balancing professional competency and expression of direction. I'm curious your thoughts on, I mean, the language that we often see used in medicine is distinguishing the personal from the professional. And that would often be used to describe maybe the dangers of talking to patients about spiritual concerns, that you might cross a boundary here. How does that kind of thinking, how is it called into question or challenged or spoken to by these sort of the emphasis on the sovereignty of God in Reformed tradition? Or maybe in the tradition that out of which you've articulated this ethic of faithful presence.
Yeah, I mean, again, to me, medicine is a complicated thing, and to understand it in its various dimensions has been extremely helpful for me, both to understand distortions of practice and corrections that are needed. One of the big ones, of course, is the economic and how that can distort practice. But knowing the other ones is just as important. And God's sovereignty over all of those ways that medicine is always in the back of my mind. You know, and I'm there as a servant to serve in these different ways that people come to me as. You know, they come with all kinds of really damaging baggage that gets in the way of them trying to understand, why is this happening to me? Why is God being so terrible to me in this situation? And each person comes differently. And, you know, in that first hour and a half that I would see a new patient, I had to try to piece that out, try to learn more from it with each subsequent visit. But that first visit was always critical. And I would have some situations where more than one family member would come. The patient would say nothing, but everybody else had all kinds of views as to how badly that person had been treated up to the time that I saw them. And then I found out through various ways that it had nothing to do with that patient's being treated. It had to do with secondary issues in their lives that got in the way of their idea of understanding their loved ones' problems. So it's very complicated. And I think I've just learned that as a Christian, understanding God's sovereignty over everything has been just extremely helpful in keeping my perspective in the kinds of virtues that I really wanted to bring forward to people. I would tell them I was a Christian if it was going to be helpful, but it wasn't always necessarily helpful. I would express myself as a Christian, whether they liked it or not. And there is a difference there. And I've talked to some of your students about that yesterday. You know, it's, how do you actually be overtly Christian, and do you have to be? And then what ways do you do that? And my answer to that is, being a Christian, like being a human being, has multiple ways that you are and develop. And I think if you develop a character that's in keeping with Christ's teaching in how we treat other people, that's where you start, and that's where you move forward in developing a practice. And I can cite a wonderful book on policy, on practice, which was published just a few years ago. And I think I had on that last slide list, which I would recommend, because that teases out practices, not just medical, but how we as Christians interact within practices, whether we're social workers or other people who interact with people. So I don't know if that helps to address that.
Let me, by the way, since you talked about a wonderful book, I'll just hold up Dr. Rusthoven's book, so you guys will get interested and go on Amazon, order that. But you mentioned whether they like it or not, you're not going to hide the fact that you're a Christian. That whether they like it or not reminds me of a real tension that seems to be a part of healthcare today, which is disagreement about what benevolence requires, right? Whether something that a patient thinks is good for them is something that you should take on their authority is in fact good for them. I mean, it connects to you mentioned in your qualifying principle or qualifying rule, benevolence being care or benevolence being essential. What do you do when you encounter folks who are asking you to do them good, and the best you can tell what they're asking for you is not good for them?
Well, a couple of patients came to me and just said, "Doc, I live in Toronto, you live in Hamilton. My doctor or my alternative medicine specialist has suggested these injections for this immunotherapy. I'd like you to do it, because it's hard to go all the way to Toronto and have one injection every other day or whatever." So I asked him to send me stuff on what it was, and it wasn't good medicine. And I said, no. I said, we're here to offer care to patients, and it's a mutual understanding of whether that's going to be helpful for them or not. And I think I can exercise, and I won't use the word autonomy, but exercise my professional judgment on whether I think this is going to be likely doing more good for them than harm. Now, that's been rare, but if it comes to that, I don't have a problem with that. People, it's a two-way street. I mean, a covenant is a two-way street.
Hmm.
And to have mutual understanding for a particular purpose for a party that's more powerful than another, the medical person being more powerful in what they know about the needs of that patient that they come to you with, takes a lot of care, takes a lot of judgment, and it takes time to establish.
Let
And
me
a
ask
lot
you
of people, yeah, go ahead.
Let me push on maybe the inverse of that. So I gave you the example of someone desires something that they say that I need this, and you don't think it's necessarily consistent with your commitment to benevolence toward them, to benefiting them. If this is a patient put through, or a question put through the chat, if I expressed to you, say I were your patient, and I expressed to you my ambivalence about starting chemo, how would you address my question about whether I'm obligated to make an effort to save my life?
Well, first of all, you have to assume that you believe that this could save their life. I've used chemotherapy more often as a palliative measure because they are not curable. And that's an art form to be able to, in the old days when we didn't have the kind of current new treatments, which are less toxic. So that is a challenge. I can cite numerous cases where I gave single agent chemotherapy where I didn't think it would do a thing, and it gave them a remission for years, people with lung cancer. So you do have to make very difficult judgment calls at times, but they're involved in that decision is that balance between that individual patient's general health, ancillary medical issues that could get them into trouble if they develop serious side effects, and their own feeling about their own care. So I would not be withholding treatment from patients after a very good discussion where I felt that they understood me, but I also understood where they were coming from. And
does someone in as you understand it, in this Christian tradition, and particularly with the emphasis on the covenantal tradition or Reformed tradition, does a person have an obligation to undergo medical treatment for cancer? What kind of an obligation is that?
for the patient?
The patient.
No, I mean, they're not obligated to do anything. They're not obligated to come to see me in the first place. And they're not obligated to see their family doctor with the problem they had that ended up being cancer. So each time along the way, they do have to have responsibility to make their own decision about their own health care. What I'm there is to give them a perspective that will hopefully be helpful for them if they're having anxieties about what decisions are right for them and how they can make those. If it's helpful to involve their spiritual walk, if they express that to me, or if I ask questions that bring that out, all the better. But there may be very different issues at hand, and that's part of the art part about being a physician in general, but particularly an oncologist or a palliative care specialist.
Let me end with this question, another question from the chat, because one of the things that you uniquely bring to this series is this experience in regulatory work and in the whole world of clinical trials. How would you suggest overcoming the problem of the research subject versus patient nature of clinical trials? How do you deal with that?
Right. Overcome isn't maybe quite the way I would put it.
Okay.
Confronting it more honestly is probably a better way to do it. As you probably know, when you're an investigator on a clinical trial, you have often a nurse or a person under you who's the research coordinator, and they will often be the one approaching the patients. You also have different levels of trials. You have very early stage trials of often patients who are very ill. And then you have randomized trials, which are trials that are intended to show true efficacy and true safety before a drug is presented to a regulatory body. So it's a constant dilemma, and I think it's a natural dilemma where, as a physician and an investigator, you have conflicting loyalties and conflicting ideas ethically, which you have to grapple with. And you don't have investigators who are pure investigators and don't see patients. Otherwise, they're not doctors anymore. You've got doctors who act too much like investigators because they don't consider the ethical issues of patient care in addition to their obligation as trying to develop better treatments and being a part of that enterprise. So you have to tease through that. And I've done it at all levels. I've done it at the phase 1 level, which is purely safety as an outcome. And I've done it at the level where a pivotal trial was being done that would make or break having a drug submitted for consideration for marketing, and everywhere in between. And it's always an issue and a dilemma. If you know of someone who solved this problem, I'd be happy to read that person.
Well, I have no doubt that one of our theology, medicine, culture trainees is going to solve this problem.
Oh, perfect.
And if you think you might be called to be the one to do that, we again encourage you guys to anyone out there to look at our hybrid program. For those of you who are practitioners already, our hybrid certificate in theology and healthcare. We'd love to have you look into that, and applications are still open to study with us. We've come to the end of our hour. Thank you all for joining us over the course of this academic year for our TMC seminar. I want to encourage anyone within driving distance to join us next Thursday, the 30th at 5:30 p.m. here at Goodson Chapel at the Divinity School to hear Dr. Russ White of Tenwick Memorial Hospital in Kenya, who is with African medical colleagues there, has built a remarkable training center for advanced surgery and is going to be our Katina, Dr. Katina lecturer in faith medicine and service. We'd love to have you join us for that. Please let folks you know who live nearby know about that as well. But thank you all. Thank you, Dr. Rusthoven. And we will see you on the seminar in the next academic year. Bye-bye.